was we found that we thought was pretty apropos. The dominant attempt to move from a craft to a manufacturing model generally leads to alienation of doctors and therefore inefficiency of organizations that ultimately depend on their commitment.
If you actually read on what's written on the slide, basically it summarizes that doctors study several years to gain a certain level of expertise. Application of evidence-based medicine calls doctors to conform to what the statistician says is the correct procedure to do their clinical practice. Doctors feel that they have hands-on knowledge to what is really happening to a patient, while expert committees ask doctors to base their judgment on a set of numbers and results. So basically in this slide, if you look at it, it is written by Miles in his article, Evidence-Based Healthcare Debate 2006, Where Are We Now? So it's a polarizing topic, which basically tells us that it's an extreme point of view of how he thinks of evidence-based medicine. So evidence-based medicine tells us that doctors, as part of their residency training and graduate medical education, creates pressure to alter the next generation of doctors' clinical practice. So it deprofessionalizes the doctors. Quality of life measurements do not differ between EBM and undertreated patients. It stresses on pro-managerial and anti-clinician stance. So their EBM basically is concerned with cost cutting. So not all questions of relevance to care to patients are scientific in their nature. Science alone can't be sole basis for clinical decision making. So basically in psychiatry, you need individual attention. It's difficult to establish protocols for that. And then for this one, it's written by our professor.
So it must be true.
So basically, this is a more rational. Yes, it is very true. It's more
Except
rational.
this is 2006. My thinking has changed dramatically.
That's a problem. But it's more rational. It's more objective. So basically, data gained on research of populations is inadequate with skills and information needed to treat individual patients. So EBM practices are either not evidence-based or based on incomplete and unreliable evidence. So clinical guidelines discourage beneficial innovations favoring by the book care. So it distills practitioners, it lowers patient satisfaction, it encourages singular interventions to inclusion of holistic approach, and EBM methods are far too impractical and difficult to implement. So basically, these are ethical questions raised during the 2007 symposium, Evidence-Based Medicine. Moving on. You can just...
Everyone get a chance to read these.
Okay, I can, well, basically, will EBM hinder physicians to express freedom in their professional goals? And the second question is, how will hospital managers deal with therapeutic procedures that do not have strong evidence base? So basically, those are like two main questions that are raised during the symposium. It will be added to the report that was there, that's not included there.
And slide 7, 8, 5 minutes. You guys are cruising.
Good. We need to be.
All right, my name is Hindu Singh and I'm a software architect at Health Plan, which is one of the leading insurance brokers in Massachusetts. And they have tried to expand into other states, but they have pulled their business back. So with that background, it gives me a little more better view of where things stand with respect to information technology and how it is used across healthcare systems. I have recently joined Tufts, but before that, for about 3 years, I was a clinical software architect, which is a very different type of technology, very different type of software than what a transactional system would do in a healthcare insurance company. So here is a list of all the types of healthcare software systems that we can think of. We have physician order entry systems, computerized CPOE as they are called, which are very popular, they are very effective. Various studies have indicated that their use has resulted in significant savings in terms of operational costs. There are imaging and radiographic applications. Most of these applications are provided by the vendor who supplies the hardware. So Siemens brings in their own CAT scan, or GE, which is a very big player in hardware for healthcare institutions. So they bring in their own imaging solutions. Pharmacy is another application, is another area where the decision support systems are very useful. They help to find the drug interactions. Maybe a patient who has taken a certain drug should not be taking another one. The lab order and lab result systems, the regular scheduling systems and the other billing systems and financial and inventory systems which are used by the senior management. These are regular enterprise systems which you would find in many of the
IT, in your write-up, I want you to synthesize that slide.
Okay.
All
All
right. A
right.
couple of central themes, not just our bullet points.
So here is a list of characteristics, the broad characteristics that you would find for a healthcare IT system. Generally speaking, healthcare is a latecomer to the IT party. If we see the financial services industry or say communication industries, where they were in 1970s or 80s, the healthcare industry is barely reaching there now. And there are reasons for it. One of the major reasons is they have huge data models to work with. You have a patient who may have dozens of encounters. Each encounter will have dozens of studies with so many images. So these data models are second only to the weather forecasting models or nuclear simulation models. These are huge. And they are not well integrated. The systems, they exist in silos. If you have a pharmacy system, it does not talk to the billing system very well. It doesn't talk to the scheduling system. It doesn't talk very well to the clinical systems and so forth. The government is lacking in their policy initiatives, which we can touch upon. And there are other issues in integrating systems. So here's the meat of the conflict. There are a whole bunch of conflicts that result from the interaction between physicians and doctors. So primarily, it can be summarized that if you introduce information technology in your hospital settings, it treats medicine as a science and not art, whereas physicians often try to see it as a artistic, partly artistic approach. They would argue that every patient is different. You cannot generalize all medicine in terms of decision support rules. And the other issue is many physicians rule the time they have to spend in learning the IT system. And the other problem is every 5 years, 7 years, they have to learn the new IT system. So that's not a good situation from their point of view. The standardized approach to service delivery is quite helped by approach or adoption of information technology. Hospitals try to run themselves lately as businesses rather than as service providers, and that's where there is this significant conflict. And the issue is also highlighted by the fact that in management, you manage what you can measure. In healthcare, it's very difficult to measure the positive outcomes. If the death rate goes down, how do you put a value on it? If patients are happy, it's hard to put a dollar figure. And the costs are tangible when you buy a system or when you invest in a IT system. You know how much you're going to spend, but you don't know the benefits. How much dollars is that?
You passed the 10-minute mark.
The last slide, this basically suggests what can be done. We can have more integration between vertical silo systems. We can have better standardization. Government basically tells what the interaction would be or how the transactions would go. They don't want to go into the storage and formats of the data. The consumer should be owner of the data, not the insurance companies, and government again needs to step into that approach. The software as a service model is an industry-wide trend. Retail is moving into that direction. So McDonald's doesn't want to be in a software development business. They want to sell hamburgers. They don't want to do the software. They want to outsource it to somebody who, it's like a lease and not a buy model. And some estimates have suggested that a 20% savings can be achieved if everybody starts using IT in healthcare, and 20% of trillion plus that United States spends is huge. It's $200 billion plus in annual savings. And there's no easy answers. hand over to
All right, so what we're going to do in this part of